Thank you very much. I'm not sure what came to Mohammed Suleiman's mind when he wanted me to talk about diabetes. I know you guys refer the patients from the first day you have any doubt, just like we refer patients with hematuria to nephrologists as soon as we detect something. But I will make it simple so that you finish this presentation with some, hopefully, things to remember in your practice. So I will review the diagnostic criteria for diabetes and improve your knowledge about glucose monitoring. This is very important. Some basic facts you need to know about glucose monitoring. And then the general themes of differentiating between type 1 and type 2 diabetes. And lastly, something, if we have time, if you have the courage to mess with your patient who is taking insulin and change their dose, I want you to know the general rule we follow in determining the dose of insulin for certain cases. So we're going to start. I have probably 5 case scenarios, so it won't be very long, hopefully. So the first case is actually 2 scenarios. First one is 9 years old, non-obese patient, presented with typical symptoms of diabetes, polyuria, polydipsia, and weight loss. Random glucose was 192 milligram per deciliter. Urine ketone is negative. And HbA1c is basically pending. Many hospitals don't have point-of-care HbA1c, so it won't be available immediately. And the second case is 8 years old, non-obese, who had a sibling with diabetes, and as usual, the mother would screen the rest of the children because she's always worried. So she did a fasting glucose on the child, and she got a reading of 130 milligram per deciliter. He is asymptomatic, he is not on medication. So you have these 2 cases. The question is, who has diabetes? Is it 1A, 1B, both, or none? Both. Okay. So actually, none. So let's tell you why. So the diagnostic criteria for diabetes, according to the American Diabetes Associations, are basically 4. Either HbA1c of 6.5 or more, fasting glucose of 126 milligram per deciliter or more, or a glucose tolerance test of 200 milligram per deciliter or more, and random glucose of 200 milligram per deciliter with symptoms. However, though, I'm not sure if there is a pointer here, I want you to see this little asterisk here, and here, and here, which is here. So it says, in the absence of unequivocal hyperglycemia, results should be confirmed by repeating the tests. So just doing a random fasting glucose on your patients and you get a reading of 126, you cannot make a lifelong diagnosis by doing the test one time. So let's reflect that on our 2 cases. This patient has the symptoms of diabetes, but the random glucose is not 200 milligram per deciliter, so does not meet the criteria. This one has a fasting glucose in the range of diabetes, but it's done only one time. So simply this should be repeated to confirm the diagnosis. So the only one that needs no repeat is basically the random if associated with typical symptoms of diabetes, because we assume that the symptoms indicate probably a continuation of symptoms for a week or more. All right, so the diagnostic criteria, I have showed them to you, right? I said there are 4 diagnostic criteria. Are those applicable to plasma glucose or whole blood glucose or both? Plasma glucose, both? All right, well, let's go back to the criteria and see. So it says actually a fasting plasma glucose, 2-hour plasma glucose, random plasma glucose. So it is not a whole blood glucose, it's a plasma glucose. So what's the difference? Well, you all know plasma is basically whole blood minus RBCs, and RBCs do not have sugar. So when you take something without sugar out of the blood, you're leaving the blood in a more concentrated fluid, which is plasma. So plasma glucose is higher than whole blood glucose by about 10 to 15%. So they're not equal, and the diagnostic criteria apply to plasma glucose. However, though, when patients prick their finger to use the glucometer Do they get plasma or whole blood? Whole blood, right? So glucometer do whole blood glucose. So the question here, can glucometer be used to diagnose diabetes? Not sure. Yeah, that's the right answer. But actually the correct answer though is yes, they can. So basically all glucometers have calibration, built-in calibration. So they measure whole blood glucose, but then they're calibrated to reflect the equivalent plasma glucose on them. So when you see a number on the glucometer, you have to assume this is the plasma glucose, even though they measure the whole blood because they're calibrated to show the 10 to 15% difference. Okay, another question about glucometer. You have a mother who has diabetic patient. She's using more than glucometer because she's obsessive compulsive. So every time she do the reading, she get different readings. She never had the same reading in the meter, different meters. So she comes to you questioning the accuracy of the meter. Your reply should indicate that 95% of the glucometer readings may have a margin of error of plus minus 5%, plus minus 10%, 15%, or 20%. 10. All right. So it is 15. Hopefully 10 will be the next generation. So according to the International Standardization Organization, the ISO, and the FDA as of 2013, they made the criteria actually more strict. It used to be 20% before that. As of 2013, any meter to be FDA approved and labeled by the ISO as acceptable, 95% of the reading should be within 15%, 99% of the reading should be within 20%. Those are the home use glucometer. The one that are used in the hospital, the professional version, should be even more accurate. 99% of the reading above 70 should be within plus minus 10%. And if the reading is below 70, then the difference should be less than 7 milligram per deciliter. So I think with the new probably regulations, which I don't know what year it will come, they will target the 10% difference until we reach something that is very accurate and similar to the gold standard measurements. Okay, case 3, you have 12 years old, obese Caucasian male. So 12 years old, obese Caucasian. Every word in the question has a purpose, okay? Except male, could be female though here. Presented with polyuria, polydipsia, and 10 kilogram weight loss. Random blood glucose 375 milligram per deciliter, which is about 21 millimole. Serum ketone is plus or 4 millimole per liter. Normal serum ketone, of course, is 0. Urine ketone is plus 4. pH is 7.34. HbA1c is 8.2%. Vitals are normal except for slight tachycardia. Child is obese. Weight and BMI both are above +2 standard deviation. He is in early puberty, and he has no acanthosis nigricans. Okay? 12 years old, obese, Caucasian, with the numbers I have showed you. Question number 1, does he have diabetes? Yes, he does, of course. He has polyuria, polydipsia, weight loss, and his random blood sugar is way above 200 milligram per deciliter, and his HbA1c is way above 6.5%, so he is diabetic, no question. Does he have diabetic ketoacidosis? No? Yes? So why no? Good, so diabetic ketoacidosis by name should be hyperglycemic, more than 12 milligram per deciliter. Ketosis means large urine ketone or urine or serum ketone above 3 millimole per liter per deciliter, and then acidosis. So our patient is having the D component and the K component, but he's not acidotic. pH is 7.34, so he does not have DKA. And the most important question in this patient, is he likely, and again I'm saying likely, to have type 1 or type 2? So he's 12 years old, he's obese, Caucasian, and has large ketone, HbA1c 8.2. So how do you tell the difference? When we receive those patients, usually we have to do two components. The first one is the anti-diabetes antibodies. If they come back positive, piece of cake, we confirm type 1 diabetes. So we finish the workup regardless of the phenotype. If the antibodies are positive, this is type 1. If the antibodies are negative, though, that does not rule out type 1, because there are 20 to 30% of type 1 diabetes patients labeled as type 1B because they need to differentiate them from the standard type 1A with positive antibodies. So those patients have the typical symptoms of type 1, but they don't have antibodies. So negative antibodies does not rule out type 1, but positive antibodies confirms type 1. So that's the first thing. The second thing is to do the stimulated C-peptide. So what is stimulated C-peptide? Is to do C-peptide when the blood sugar is high. You don't do C-peptide when the blood sugar is normal. And the reason is C-peptide reflects how much insulin comes from endogenous secretion. We don't do insulin level because if patient is taking insulin, it interacts with the assay. So you will have high insulin level because patient is taking insulin. So insulin level is affected by exogenous and endogenous insulin, but C-peptide is only reflecting endogenous insulin. So if you need to know if your patient can make insulin, increase their blood sugar, and you would expect when the blood sugar is high, they will make more insulin. So you measure it, and if it's high, it's type 2. If it's low, it is type 1. Yeah, victory, I saw that. So basically, type 1 diabetes or new onset diabetes, is your patient obese, then you think it's gonna be type 2. You measure C-peptide. If it's high, you made the diagnosis. If the C-peptide is not high, you measure antibodies. If it's positive, you made the diagnosis. So high C-peptide helps you, positive antibodies helps you. In between, you might have a type 1A, type 1B or MODY, and that's basically the gray one. So this patient is likely to have type 1 rather than type 2. The reason is he has very high ketone, but the HbA1c is not very high. For type 2 patients to have large ketone, they have to be very progressive. And HbA1c by then will be in the 10, 11, 12. This patient is not like that. He doesn't have acanthosis, which is insulin resistance marker, and he's Caucasian, and type 2 is less common in Caucasian. Case 4, just again, if you want to know how we calculate insulin dose, and this will be the last case. So 12 years old, type 1 diabetes for 3 years. He takes 22 units of basal insulin, 8 units of prandial insulin with meal, and his random blood sugar is 225, and now he wants to take his prandial dose. The question is, how much would you recommend for him to take? 9, 11, 13, or 15? So let me, for the sake of time, again, he's taking 8 units for the prandial, so how do we calculate his dose? Usually, the basal bolus regimen is split into 50% of the total dose as basal, 50% is total prandial, about, okay, not necessarily exactly. But then on the top of that, we have to give correction when the blood sugar is high. So how do we calculate the correction? Basically, correction is the amount of insulin you have to give when the blood sugar exceeds target. What is the target? A simple rule to remember, children of 10 and above have a target blood sugar of 100. So once the blood sugar exceeds 100, you need to start calculating the target. How much to give? You need to use the rule of 1800. It's a random number. 1800, you divided that by the total daily dose of insulin, and you get the sensitivity factor of how much correction you need to give. So let's do the example in this patient. He's on 22 basal and 24 total prandial. That's total daily dose of 46. 1800 divided by 46 is 39. Make it simple, so that is 40. So the correction factor is 40. The target is 100, which means for every 40 milligram per deciliter above 100, you add 1 unit. So let's apply that to the example I gave you. His blood sugar is 225, target is 100, so the extra blood sugar is 125. Divide 125 by the correction factor, which is 40, and you get 3 units. You add the 3 units to the prandial dose, which is 8, and you get 11 units. In case you want to take the risk and manage your patients, that's how you do it, okay? I was basically had another case for practice, but for the sake of time, I'm gonna pass it, and my daughter forced me to put a non-diabetes related questions, as I usually do. And my question is, what was the most ordered food on Talabat in the year 2021, when we still have in COVID effect? That's in UAE. Is it pizza, chicken sandwich, French fries, coffee, or burger? Now you all have to participate. Pizza, raise your hand. No, the most common. All of the above are common, I agree with you. So I saw maybe about 10 answers for pizza. Chicken sandwich. Nobody. French fries. Few hands for French fries. Coffee? About 10. And burger. So probably pizza and coffee got the... Okay, well, my daughter told me to take number C because it makes no sense, but actually that was the most commonly ordered food according to Talabat report for 2021. So thank you very much.
Thank you so much, Dr. Kaplan, for this very interesting and very nice